Welcome to All Things Chiropractic.
Welcome to another episode of All Things Chiropractic. I'm Paul Andrews.
I'm Dr. Mark Davini.
There he is. Hey. Okay.
In the room.
What are we talking about today?
We are talking about Medicare. Hotel California. And we'll make that point clear later.
Yes, for us that are myself or younger, have no idea what you're talking about.
I think the whole world knows the Eagles song, Hotel California.
The Eagles? What's that?
But you will know it when we're done. And it's really Medicare, risk or benefit.
Ooh. So 3 terms come to mind when we think about Medicare and chiropractic. What are those 3 terms?
The good.
Wah, wah, wah.
The bad. And the ugly.
Anywho, so if we're talking about those 3 things, Doc, what is so good about Medicare and chiropractic, by the way?
And I like Medicare. And I know all people just fell over in their chairs. And the reason for it is...
Don't tune out. Don't tune out.
Don't tune out. Don't tune out. And I'm going to tell you why. Okay. Medicare is the only one that is clearly defined. For example, they're the only carrier that lets us use the term subluxation. They're the only carrier that assigns the term subluxation to a chiropractor. They're the only carrier that actually has a code that they label the subluxation and assign it to the chiropractor. So it's exclusivity to chiropractic. They're the only ones who really have addressed us as a profession separately and distinctly, where all the other carriers tend to sort of generically lump us into some other category with the hope that we'll go away.
One could say that the feds have validated subluxation as a term in chiropractic.
It's in the Federal Register because unlike regular insurance carriers, Medicare is federal law. It's not policy. It's not opinion. It is actually in the Federal Register. And to change something in Medicare literally takes an act of Congress, which everybody knows
Good luck
they're
changing
trying to
anything
do.
in Medicare.
Exactly. Okay. But for the most part, even though there's limitations to it, what they do define is very clear. They tell us what we treat. They tell us how we can treat it. They tell us how long we can treat it. And they even define what we can do after we're done with them. So Medicare is not as bad as it sounds. And for the most part, if you think about the demographic that's involved in Medicare, those that are Medicare eligible or anybody on Medicare disability for the most part, but in the senior population, even though they may not have the most money as a demographic, they have the most discretionary cash as a demographic. So they can decide what they spend their money on, and they have the money to spend it on more than any other demographic. It's important.
To translate that, they may not make the most money, but most of their stuff's paid for. So they have
Right.
they have extra money.
Right. They walk around with more cash in their pocket than I do. That's
Right.
for sure.
They don't say that.
Right.
but-
They don't say that. I'm not saying they won't complain, and I'm being kind on podcast radio here or whatever, podcast, saying that that they will complain.
Yeah.
They will moan.
They're not the
a
only
little
ones.
bit. And they're not the only ones because money is always an issue. But what I'm saying is that they, as a demographic, not to say there aren't those people on very fixed incomes that are very deficient in satisfying their needs. I'm not belittling.
All right, you
that at all.
qualified this statement. Okay.
Okay.
Hey, by the way, you are one of those people,
I
Mr.
am.
Medicare, so
Yeah.
you
Which
can
bring-
talk about your group all the time.
Exactly. It'll bring me to the next point. We all need it.
Yeah.
You start hitting a certain age group, chiropractic becomes a requirement, not
Yeah,
a choice.
Right. Necessity.
It's a necessity. So, yeah, I do like Medicare. It's just one of those things where you say, wow, nobody really has acknowledged us as a profession and dissed us as a profession more
Right.
than Medicare,
Right.
which brings us
yeah.
to
the bad. Yeah. Yeah. It's almost, you could say, the duality of it too, right?
Right.
Yeah. So when looking at it's thanks for giving me the bad portion because it's really easy. I could just go on all day about the bad.
Yeah, well, you're the bad boy, so yeah.
Yeah. So the rules for a, I'm not going to say a carrier, for a government entity that pays for so little in chiropractic, they have a lot of rules. rules that you have to stick by, stand by. I would even say that some of them feel a little anti-chiropractic. And what do I mean by that? Meaning the rules are clear. The good news is the rules are pretty clear. People like myself and Dr. Davini help people understand them because, until you're used to reading them, they might not be so clear. But the reality is, if you read like the maintenance, the term that what Medicare considers maintenance in chiropractic,
Oh my God.
right? It's clear what they're saying.
Unfortunately.
But it is sort of anti-chiropractic because it's everything that not only a Medicare patient wants, but a chiropractor wants to help a Medicare patient achieve, right?
And it's similar though to carriers because we've always talked with carriers about things like wellness care and maintenance care or whatever. And a lot of times they'll say, hey, look, it's not that we don't believe in it. We just don't want to pay for it.
Yeah. Right. And so, again, one of the negatives or the bads is what they cover, which is really easy to outline. They only cover the spinal chiropractic adjustment.
Then how come we always see everything but on non-covered service waiver forms like
we'll get to the end, but so there's only three service codes in the books of thousands and thousands.
A Federal Register.
Yeah. So AMA CPT gives a book out every year. It's a hunky book with thousands of codes, but there's only 3 in that book that Medicare will consider covering in a chiropractic office.
So otherwise, it's another good. I only have to remember 3.
Yeah, from reimbursement, it's not so great, but yeah.
Procedurally, I only have to know 3.
Right. And so the other sort of the duality of it here is patients will walk in because they're hurt. But in actuality, when you look at Medicare's rules and policies, pain isn't what they consider or care about. It's not pain. It's what? Function, right? So when you're talking about, a patient who has pain will likely have limited function, right?
And if you're a senior, you most likely have pain almost somewhere, somehow, all the time,
right? Or limited function. You have degenerative stuff going on, and you're can't do what I used to do, right? So there's outcome assessment tools that you would use for metrics to help measure that, things like that. So again, it becomes fairly plain as you weave yourself through the rules, which are a pain. What, to me, one of the things that's kind of aggravating about Medicare, one of the 2 things we're going to talk about here is the fee schedule. Because even though there's only 3 codes, the spinal chiropractic adjustment that Medicare would consider reimbursing, there are 3 fee schedules attached to those 3 codes.
Now, I didn't say that it wasn't complicated.
Yeah, right. Exactly. They're just, And so anyone who knows a little bit knows that there's the participating fee schedule amount, the non-participating fee schedule amount, and also the limiting charge fee schedule amount. So
my head just exploded.
Yeah.
Go ahead.
And I don't want to get into the weeds about the fee schedule other than to say that in your office, you should know whether you are a par or non-par provider. And if you're like, well, I don't take Medicare, doctor, I don't deal with Medicare. I don't even have a Medicare provider number because I don't bill Medicare. I am just a cash practice. What do you think of that?
That brings us to the ugly.
Exactly.
Brings us right to the ugly. Chiropractors cannot opt out of Medicare. And this is where the title of the podcast comes in. Hotel California. To quote the song, you can check out anytime you like, but you can never leave.
Exactly.
And that's Medicare. We're the Hotel California of Medicare is the Hotel California of chiropractic. And that comes from way back. The Medicare Benefits Policy Manual states and quotes the opt-out law, where it defines that a physician, a chiropractor is not a physician, which means we are not on the opt-out list. So going further with that, we have this crazy terminology, again, because Medicare does like to complicate things, of par, participation, participating, or non-par, non-participating.
The
And
terms are bad. The terms are awful because
So what's the difference between non-participating and opting out?
opting out means you can just disregard Medicare altogether, which you can't do according to the opt-out law. So non-par means that you'd like to limit your interactions with Medicare as a provider. That's really what you're talking about, is limiting to the best that you can under the rules how much you interact with Medicare.
Yeah, Medicare would equate par and non-par as being in network and out of network. The difference
essentially.
being, if you're out of network, meaning you're non-par, you're still in Medicare.
Yeah.
Which means you have to follow all the rules. You just have to follow the non-par side of the rules. So if you consider yourself out of Medicare because you're non-par, that's not true, is it?
Not only is it not true, Medicare is unlike every other carrier and entity under the sun, because for you to obtain a PTAN, or provider transaction access number, which is basically your Medicare provider number, to obtain that on the application, it says, when did you first see a Medicare patient? Now, most carriers, you're used to saying, well, I have to contract, wait for my welcome letter, know the effective date, then I'm in network, then I'm able to see these patients under network coverage. Medicare says you can't even apply for a Medicare number provider until you see a Medicare patient, which means that the effective date will be the day you see that Medicare eligible patient.
Yeah. So you're really not applying for Medicare. Medicare is saying, just by virtue of you being a chiropractor, you're in Medicare, and you have to validate or credential. You have to validate more than credentialing. It's a validation that you will be treating them either as a par or non-par provider.
Essentially, Medicare is saying to the provider, the minute you see one of our members, our Medicare patients, you're subject to all things Medicare. We don't care if you put in an application or not. We're going to protect our members the minute you see them. Period. End of story.
And that means that for active treatment care, you are in Medicare the second you treat a Medicare patient, and you cannot treat them. You cannot refuse to bill, in a sense, Medicare patients under active treatment, and even if it's just for cash. So once you're in Medicare, you are required for active treatment. You are required to bill Medicare based on the direction of the patient.
Yeah. That's really what it comes. It kind of leads us into the ABN discussion a little bit, doesn't it?
It
that
does.
Advance beneficiary notice. Because I can tell you that when we get questions about the ABN, which is a lot by our members, a lot of times they're just using the form wrong. They're using it as a non-covered service waiver form. Right.
But again, Medicare is very clear about what it can and cannot do.
Right. So, Doc, what is an ABN actually used for? What services would an ABN be used for?
An ABN is used for any service that might be covered by Medicare.
Well,
I mean, it is covered by Medicare, but might be reimbursed or may not be reimbursed. So it's a covered service that may or may not be reimbursed based on the circumstances, as opposed to a non-covered service, which is never covered statutorily.
So if we tie this back into what we said previously about what Medicare covers in a chiropractic setting, if the ABN is only used for those services that Medicare would consider covering, how many codes are we talking about?
1, 2, I count 3.
3. 3. That's
3.
it.
So nothing on an ABN other than those 3.
If it's a spinal chiropractic adjustment, there's 3 codes Medicare might consider paying. That's the only 3 codes that belong in an ABN, period, end of story. That's it.
So we're not denying that Medicare has a lot of complexities and idiosyncrasies. And an ABN by itself is a whole other podcast on its own. But there is a trend happening out there, Paul, and it's very disturbing to me as a chiropractor. And it really literally makes my blood boil.
So I think you're going to refer to the options that are on an ABN and how certain people conduct directing patients or not, perhaps.
There's that one.
Yeah.
There's also another one. So we're going to get to both of them. So yes, if a patient comes into your office, they go through active treatment, they've reached maximum functional improvement, you now hand them an ABN because they're going to transition from active treatment to maintenance wellness, you're not supposed to be able to direct them as to what option to choose. So there's 3 options. We won't even talk about the third one. But one is saying you bill or not bill, and the other one, you bill or you don't bill. If you choose option 1, the patient is directing you to bill. Even though it's maintenance, even though you as a doctor know it's not covered, and you're probably not going to add the AT modifier, which is telling Medicare it's not covered, and you'll put GA modifier. Yeah, you'll put the GA modifier on saying, I have assigned ABN. You explain this all to the patient, and they still choose option 1.
They agree to pay you, but they want Medicare to process the claim.
They basically say, I'm not sure I believe it, but I'll pay you, but let's see what Medicare really has to say.
Yeah.
And there's a situation, too, if a patient's dual eligible, where they're Medicare and Medicaid, where I love this language. The feds tell you that you have to direct them to choose option 1.
Even though you're not supposed to direct them to choose any options. Right on the form, it says, we cannot choose for you.
But if you're dual eligible, you have to direct them to choose option 1. So there will be circumstances in your office, whether they choose option 1 or not on their own, that they may be required to check off option 1. So you do have to be able to bill Medicare even in the maintenance phase. Option 2 is nirvana. They check it off saying, I know that it's not Medicare is not going to cover it. I know I have to pay you, and don't bother billing for me.
Yeah.
So if a patient comes in and now you've treated them through active treatment, and you've brought them to a point where you're handing them the ABN, and they check off option 1, or they are directed to choose option 1 because they're dual eligible, you cannot refuse to treat them. I got that straight from Medicare in writing. You can't say, go somewhere else because I don't bill Medicare, or I don't bill maintenance visits to Medicare. You can't do that.
Even if you know somebody or some clinic that's doing it, it isn't right.
I have it in writing, in black and white. Medicare says you
want to. You want.
This is something we all want the option to do, right?
Yeah.
So just say, great, you hit maintenance. I don't care what option you choose. If you don't choose option 2, go somewhere else, which most patients will probably say, okay, give me another one and I'll check off option 2. But you can't refuse a patient's treatment based on the fact that they checked off option 1 or are required to, or you direct them to choose option 1.
Right. Not to be confused with option 3, because if they choose option 3, they're basically saying, I believe that it's not covered, but I don't want to pay you for it.
There you go. Thank you.
They're dismissing themselves from care.
Yeah, they pretty much just said goodbye. Thank you. I don't need you.
We didn't even talk about the fact that the ABN, even though there's one ABN form, there's actually 3 versions of the ABN.
Yeah, that's why it requires its own podcast. Yeah. Because, again, as much as I like Medicare, because it has a whole bunch of rules that you need to follow, but once you follow those rules, it's pretty straightforward and pretty clean. But
there it is.
Let's get to where my blood is boiling on the other subject. There's a trend out there right now where they're being told, we'll say by a prominent organization in chiropractic, where they're telling people, just don't adjust seniors. Do everything else. Do the therapies.
Wait.
Yeah, I know.
Wait a minute. Aren't they saying that if you clinically decide through objective findings that there might be a risk not to adjust? Aren't they saying that?
No, they're saying Medicare is too complicated and the risk of them coming after you is so great. Do yourself a favor. Just don't even adjust them. Do all the non-covered services, but don't do the only covered service. Don't adjust them.
This is chiropractors now. This is what they do for a living.
This is a major organization in chiropractic directing chiropractic, or at least suggesting that this is an option. And, I really have a clear path in my mind for this. Number one, it's fraud.
Yeah.
Because what you're treating is not what you found.
Right.
You find a subluxation, and the only treatment that can address that subluxation is a chiropractic adjustment. Medicare recognizes that. It's in the Federal Register. So if I ignore that, I'm not doing what's best for my patient. And I'm asking them to pay for services that sort of dance around the subluxation, but don't address the subluxation. Oh my God.
That sounds like they're violating my mantra, which is the doctor treats the patient and the biller treats the claim.
Right.
Now it sounds like the doctor's treating the claim And I'm confident that probably in all 50 states, there's a reg that has something to do with the doctor having to treat a patient ethically, compliantly, and in the best interest of the patient.
Oh, absolutely. Say I needed open heart surgery, which is a very risky procedure. And your surgeon goes, it's just too risky. I'm going to do an appendectomy instead.
Yeah.
Right?
I get paid better for an
I get
appendectomy.
paid. It's easy. I'm in and out. It's quick and easy, and I can get paid better for it.
Right.
So number one, it's fraud. Number two, it's complete violation of our oath as a chiropractor, that we want to help people. We don't want to hurt them. And doing everything but an adjustment is hurting a senior. And let's face it, we all have subluxations by the time we're at that point in our life. So it's just wrong. And essentially, you're practicing physical therapy, because I'll do anything and everything but adjust. So people out there, I'm going to say this plain and simple. If this is something you consider, if this is something you do, please do me a favor. Get out of the profession, because you're not helping them and you're not helping my profession. We have an identity problem enough as it is, without having chiropractors out there not doing what chiropractors do.
Well said. And you think about it, you're that doctor who decides, I'm not going to adjust because some organization said, don't bother.
Yeah, we're not saying it's not clinically risky.
Yeah.
You know what I'm saying? We're saying that an adjustment is safe and sound and you can do it, but because procedure is so complicated, I'm not going to adjust you.
If you don't adjust because of the patient's, risks, that's understandable.
That's different.
But are you going to tell a judge and get cross-examined, and when they ask you the question, doctor, would an adjustment have helped better? Or could you have adjusted them? And your answer is, well, yeah, I could have.
It's just too much of a hassle.
Right. Or I should have.
Yeah, but it's still too much of a hassle. I don't want to do it. So,
or somebody told me I didn't have to. Well, their name's not on that claim or on that documentation. It's your name on there.
And if you take the adjustment away from what we do, we're not chiropractors anymore, because it is what we do, and everything else is supportive to that.
Exactly. And most state laws probably echo those types of sentiments in their rules, regs, and statutes. So where do we go? I mean, we've talked about some of the ugly. We've talked about some of the bad, some of the good. But right now, chiropractic is in this place where they only cover these 3 codes, which is, the chiropractic spinal adjustment. And the rules seem pretty, I wouldn't say they're not simple. They can be complex, but they're in black and white. They're there. Again, people like yourself and me help people interpret and understand them. But, do you think there ever would be an expansion of Medicare coverage?
Well, we can always hope, because, again, if you watch chiropractic's progression through the years, we've have made huge changes. And we know that right now there are bills filed in Congress to expand our covered services for chiropractors, exams and x-rays and such. So yes, I do have hope, because who loves chiropractors more than seniors? So we have the population that loves us most. We have people who are younger who will become that population who will love us most. So yes, I do think that chiropractic can expand. Maybe we can go so far as to redefine some of the silly things like their definition of maintenance, and make chiropractic more accessible to everybody under the Medicare statutes. But for right now, I think the simplest place to be is learn the rules. Like Paul said, that's something we do all the time, is teach the rules. Learn the rules, create procedures around the rules, and then prosper with Medicare as it is today, with the hope that it gets better tomorrow.
I have to digress for a minute, because I think one of the things that hurt the potential expansion of coverage in chiropractic was, do you remember the demonstration project that happened a decade or so ago?
Mm-hmm.
They decided on a couple of regions of the country, I think Maine, this parts of Maine, Chicago, some other areas of the country, and they did this demonstration project of they expanded coverage in just these areas, and chiropractors could bill and get paid for exams, x-rays, modalities, therapies, to see Was there any better outcomes with patients, diagnoses that were reported? And, basically, was it worth the money? And I think where chiropractors didn't do themselves a favor, and not the ones listening, of course, but there was rampant fraud. Rampant fraud, like 100% fraud.
We tend to be our own enemies when it comes to those kind of things.
Yeah, it was really disappointing because I said to myself, here's an opportunity to demonstrate to the federal government that if you just give the chiropractor some more reimbursement, you're going to see these patients thrive. But no. I mean, I'm talking about really rampant fraud, unfortunately.
and it comes from chiropractors who have a similar mentality to what we just talked about, that they would be willing to not adjust somebody just so they could get paid for non-covered services. So their mind isn't in the best interest of the patient or the best interest of the profession.
Doctors, treat your patient.
Yeah.
Billers, treat your claim.
Yeah.
Right? So
absolutely.
Our members moment, we kind of alluded to it a little bit, but we get a lot of misuse or misunderstandings on how to use the ABN. So we did talk about the fact that an ABN is only used for the chiropractic spinal adjustment codes. That's the only time you would pull out the ABN when you're going from active treatment to maintenance. You've clinically determined their maintenance and you want them to continue under maintenance, right? And so they pull it out.
Like I said, the ABN is a podcast in and of itself.
But the question is, well, how do I handle the non-covered services, doc? Like, what do? I can't put it on the ABN, but I want them to pay for it.
You would use a non-covered service waiver form, and that can take the shape of a good faith estimate, which is the No Surprises Act that we have to follow. So again, there are rules. We're never going to deny that there aren't rules. These aren't specifically Medicare rules. They're just rules. But follow the rules, put the procedure in place, and never think about it again.
And then the other sticky wicket, I think, for some members is understanding active treatment and then when they end up migrating to maintenance. Like, what does that look like?
Right. And I know a lot of people like to say, oh, boy, but these patients need it. Without it, they regress and all that. And we know that. And Medicare knows that. And if you read the definition of maintenance, you could see how they have covered their butts as far as making sure that anybody on regular care, and if you read that definition, it just comes out to be anybody on regular care is considered maintenance. And they don't cover that because regular care doesn't improve them functionally overall. So, and again, it's a complex concept that we will discuss in the future for sure. But as it stands right now, know the rules, know when to treat, know how to treat, know when to quit treating under that particular category, like active treatment, and then know when to bring in paperwork like ABN, and then know how to treat them as a maintenance patient. Once you know the rules, they're great patients.
Right. That's where I think the anti-chiropractic aspect comes from, because once you understand Medicare will pay to improve their function, but they will not pay to keep them from regressing. They won't pay for them on the downturn, so to speak. They'll only pay for them on the upturn.
Right. It's catch and release as far as symptoms go.
For reimbursement, not the patient in general, right?
Right, because these patients, believe it or not, we have some of the largest Medicare practices that I know have converted over to non-par status, and that when the patients hit maintenance, they tell their patients they have to pay, and then eventually, if they did direct them to option 1, they will change their mind and change it to go to option 2 and not bill. And then life goes on. These Medicare patients come in at their regular intervals. They pay cash. They're happy. The doctor's happy. Life is good.
And you know what? If some make choices that they can't afford the maintenance part, and you release them, and then they come back because they relapsed, that's not on you. That's okay. That's just part of their decision making in their life. You can't.
Exactly. So here's a closing thought.
Yeah.
It's just time to put the care back in Medicare.
Ooh. On that note, thank you so much for listening to another episode of All Things Chiropractic. I'm Paul Andrews.
Dr. Mark Davini. Thank you.
Thanks for listening to All Things Chiropractic. We'd love to hear from you. Visit allthingschiropractic.com with comments, episode ideas, or questions. Or connect with us on Facebook and Instagram at All Things Chiropractic Podcast. Be sure to join Dr. Mark Davini and Paul Andrews next time for another episode of All Things Chiropractic.